Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video using the iClearScope endoscope, and it's a really interesting case for you guys. You can probably tell that by the duration of the video, it's just shy of 26 minutes. And it's of a patient who attended with a possible underlying rare external auditory canal cholesteatoma, and I'll explain what that is during the course of the video. I actually uploaded this patient's right ear procedure earlier on in the week, and I did make reference in that video to the fact that I will be uploading their left ear as a separate video. I just felt it required its own separate video due to the complexity of the case and also due to their underlying pathology. So it gives me a bit of time to explain what a cholesteatoma is, and more specifically what an external auditory canal cholesteatoma is. So what you're seeing in this patient's left ear is a plug, a really hardened plug of wax and keratin. It's so dry, it's really compressed against the canal walls, which makes it really hard to remove. And it's probably the length of this plug is between 1 and 1.5 centimeters. So you're just seeing the surface. Because it's so dry and hardened, I realized almost immediately that I'm not going to be able to remove this solely by performing microsuction. So I reached out here for the right ear hook and the pick, and I did manage to break up the most lateral surface of this plug of wax and keratin, but I've got no choice, but I'm going to have to use the metal instruments to remove this. I don't often use the metal instruments. So when I say the metal instruments, I'm referring to the metal version of the St. Bart's ear hook and also the correct. Purely because it's got such high tensile strength, if you do come in even the slightest bit of contact with the canal wall, it can be really uncomfortable for the patient. However, I needed that additional strength. Although the right ear hook and pick is made up of carbon fibers, so it itself is extremely strong and durable. For a plug like this, it's just rock solid and like stone, it's just not going to be strong enough. And you're going to see me revert to that in a moment. I also use forceps. They've got quite a narrow ear, there's a few hairs here, they're like whiskers. I did actually trim a few, but some of these are a bit deeper in the ear and it's hard to get access. So I know some of you are going to hate viewing this video, but this is the reality of what we do. These are the complex cases. This is what audiologists like myself, GPs, ENT nurses who perform earwax removal, these are some of the circumstances that we have to adapt and overcome to remove earwax. So I know some of the videos, they've got that money shot, you've got a wide, massive ear canal, there's no hairs, it looks picture perfect, but the reality is some people's ears are like this, and we have to try and work around that. Okay, so whilst you're watching this, so this is the right ear hook, so I managed to just kind of glide it underneath and separate it somewhat from the floor of the ear canal. I'm going to explain what a cholesteatoma is. So a cholesteatoma is a dead skin cyst that forms it can form in the outer ear, but also in the middle ear. And this dead skin cyst, it's locally destructive. So if it grows, which it can, so it's self-growing as well. That's another important thing to remember about cholesteatoma. It's like a tumor, but made up of dead skin. If it begins to grow, it can be locally destructive. It can invade adjacent structures of the ear, and it can lead to infection of different parts of our anatomy that surround the ear canal. And in the worst case scenario, it can be life-threatening. It can go upwards towards the brain and lead to a brain abscess, meningitis, and potential death. So a cholesteatoma is not something to turn a blind eye to, and this is what concerns me, that some people who are performing earwax removal are not clinicians, and they just don't have this underlying knowledge that and diagnostic skills to identify a cholesteatoma, for example. That's just one of many potential really serious and potentially life-threatening conditions that we can encounter during a normal earwax removal appointment. So a cholesteatoma is a formation of a dead skin cyst, and it continues to grow. And there's 4 types. In an earlier video, I think a couple of weeks ago, I said there was 3, but I stand to be corrected, there are 4. The most common form of a cholesteatoma is what we call a middle ear cholesteatoma. And that generally develops if a patient has a retracted eardrum. I know some of you guys have been watching for many years, and I've explained this several times, and I do apologise, but for anyone new, it's good for me to just explain what a retracted eardrum is. So our eardrum, which is probably 2.5 centimetres deep into the ear canal, behind that we have the middle ear. The middle ear is a cavity that should be air-filled, and the air pressure in the middle ear should be equal to the air pressure in the atmosphere. When the air pressure is equal either side of the eardrum, that's when we hear the best. That's when our eardrum is most mobile. There's a tube in the middle ear called the eustachian tube, which connects to the back of the nose, the nasopharynx. So it kind of connects like that, which is responsible for equalizing the air pressure in the middle ear, so it's as close as possible to the air pressure in the atmosphere in the outer ear. If that eustachian tube fails to operate, so if it's dysfunctional for, there's many reasons which I won't go into in today's video, but if it fails to equalize the air pressure, it means there's no air in the middle ear. So it creates negative pressure, which causes your eardrum to get sucked in, and it typically gets sucked in at the top part of the eardrum, the region called the pars flaccida. And that's just because that part of the eardrum is more elastic than the pars tensa, which is the main body of the eardrum. So you've got this retraction pocket. This eardrum is sucked and cupped inwards at the top of the eardrum typically. Now, the outer layer is the eardrum, so the eardrum has got 3 layers, but the outer layer is formed of epithelial skin cells, the same epithelial skin cells that line the inner 2/3 of the ear canal. And this skin that lines the outer portion of the eardrum, as it sheds, it moves sideways out of the ear. It's like a conveyor belt. So imagine the center of the eardrum, you've got all the skin cells, it radially migrates outwards to the edge of the eardrum, and then it eventually migrates sideways out of the ear. But if you've got this sucked in eardrum, as the skin is migrating radially, the skin that's going towards the top part of the eardrum, it falls into this retraction pocket. So it's no longer migrating laterally out of the ear, it's actually going the opposite way, if anything. And it forms into a cyst. And this cyst continues to grow. And as it grows, it becomes infected. So you've got bacteria involved in this skin cyst. And this bacteria then releases what we call proteolytic lysosomal enzymes. And these are like digestive enzymes. They start digesting and decaying anything really it comes in contact with. So it could be whether it's the skin or any bone or the facial nerve, or if it goes upwards towards the brain, the meninges. So it's not something to take lightly, as I mentioned earlier. Now, the type of cholesteatoma just described to you, we call that a middle ear cholesteatoma. You can get also a congenital cholesteatoma. So that's when, for some reason, some of this epithelial skin that lines the ear canal or the outermost layer of the eardrum, at birth, there's some of the skin in the middle ear where it shouldn't be. So it could just be a case of mutation. Some of the skin that lines the middle ear, which is mucosal skin, that somehow mutates into the epithelial layer skin, for example. So that's called a congenital cholesteatoma, and it can present itself as a white mass. So this dead skin cyst, at its early stage, it's kind of like a white mass, and then it can change color, it can oxidize, it can go yellow and into a dark brown. But they're normally visible when you perform otoscopy. So otoscopy is the procedure that we use to examine the ear. On what we call the anterior superior quadrant. So in the case of this patient's left ear, it would be visible between say 9 and 12 o'clock. If it was the right ear, it would be between 12 and 3 o'clock. And it's like a white mass. It may actually look a bit like scar tissue, so laryngeal sclerosis or tympanosclerosis. And as I said, it's normally detected in the very early years of life. You then get what we call a secondary cholesteatoma, and that can occur just for example, so say for example, if a patient has a perforation of the eardrum, and as the skin is migrating off the eardrum, it kind of goes into the perforation. Or post-surgery, so if a patient has surgery which involves the lifting of the eardrum to gain access into the middle ear, there could just be some skin that's kind of cut away during the procedure that enters the middle ear, for example, or when the eardrum is kind of placed back into its normal position, somehow the skin kind of just abnormally sheds into the middle ear cavity. So that's a secondary cholesteatoma, and it's normally post-surgery or post-trauma. So as I said, someone has a hole in the eardrum and the skin migrates into the middle ear. Then you have a canal cholesteatoma, which is what this patient potentially has. So a canal cholesteatoma is when this dead skin cyst forms in the ear canal. So it's not anywhere near the eardrum typically or in the middle ear, it's more in the outer ear. And you get two types of an external auditory canal cholesteatoma. You get a primary canal cholesteatoma and you get a secondary canal cholesteatoma. So a primary canal cholesteatoma is more idiopathic, and it's typically due to iatrogenic trauma caused by the patient or even by a specialist myself when removing earwax. So it's when somehow the skin is not coming out the ear. So the primary type of ear canal cholesteatoma is when, for example, if a patient uses a cotton bud, they graze their ear, they cause some trauma, that can lead to some swelling, for example, or you could actually ulcerate and lacerate the skin as a trench created in the ear canal. And as the skin is laterally migrating, it either can't get over the obstruction due to the swelling, for example, or if you've lacerated and ulcerated the skin, you've created a trench. The skin will just fall into that trench and then eventually form into a cyst. So that can be caused by the patient, or it can be caused by a specialist like myself. When I'm cleaning the ear, for example, I could be grazing the ear canal and cause some trauma. That's your primary. There can be typically singular episodic, so it might just be a one-off case and you treat that successfully and it doesn't come back. You then get your secondary canal cholesteatoma, and that's when it's more because this patient's skin has failed or has slowed down in its shedding of the skin, this lateral migration of skin. So as I said, the skin that lines the ear canal and the eardrum is continuously replacing itself, and old skin is naturally sheds out of the ear in this conveyor belt motion, and it's replaced by newly formed skin. But if that skin fails to migrate, or it does migrate but at a slower speed, then it can eventually form into a cyst in the ear canal. So reasons behind a potential slowing down of epithelial skin: age, for example. So as we get older, there's reduced blood flow. So what fuels this migration of skin is blood flow. So as we get older, we will possibly have reduced blood flow, which slows down the migration of skin. Radiotherapy, for example, can damage the epithelium and also the deeper layers of skin, and also the blood vessels, which provide obviously the blood and the oxygen nutrients for the skin to migrate. So they're possible reasons. Diabetes as well, potentially as well. So you have reduced due to arteriosclerosis, so plaques forming in the blood vessels, so you get reduced blood flow going to the ear. So these are all potential reasons. So a canal cholesteatoma for that reason is more common in the elderly population. They're not to say that it's not possible to occur in younger patients, but it's more of a geriatric pathology. Whereas keratosis obturans is actually the opposite. It's more common in patients below the age of 40, because with the keratosis obturans, which is a plug of dead skin, so it's not a cyst, it's just a plug of dead skin that doesn't metabolically reproduce itself like a canal cholesteatoma does, and it doesn't release these dangerous proteolytic enzymes, which actually is one of the main issues with the canal cholesteatoma. So you've got this canal cholesteatoma. How does it do damage? Why is it dangerous? Why does it need to be treated? So, as I mentioned earlier, as this dead skin cyst continues to grow, there's bacterial involvement, and this bacteria then can release these harmful enzymes, these proteolytic lysosomal enzymes, and these are as I said, digestive, so they can start ulcerating the skin. So you have some piece of the skin missing on the ear canal. The cyst falls into that kind of trench created by that ulceration. Then you got the periosteum. So the periosteum is like a thin sheath, a membrane that lines the bone, and that supplies the bone with all the blood, oxygen, nutrients that it needs. But if that periosteum gets infected because of this dead skin cyst, you get inflammation of the periosteum, you get osteitis, which then means the bone is starved of all the blood that it needs, and that can then lead to osteonecrosis, so the decaying of the bone. And then that bone gets infected, and that infection of the bone, it spreads around the ear. So a canal cholesteatoma normally is on the floor of the ear canal, but you can also get it on the posterior canal. So you're now beginning to see the early stages of this canal cholesteatoma revealing itself as we're moving this plug. You can see about 4 o'clock this white layer of skin, and you can see there's a little trench there, and you'll see it a bit more as we continue. So if a canal cholesteatoma spreads anteriorly, it can affect your temporomandibular joint and your parotid gland, which is your main salivary glands, which are located kind of to the front of the ear, but also a bit downwards. But it can also affect your temporomandibular joint. It can actually cause a herniation. So if that bone is completely eroded, whenever you open and close your jaw, the soft tissue around your TMJ, it kind of goes into the ear canal. And I've seen it before when patients open and close the jaw, you can see all the soft tissue entering the ear canal from the temporomandibular joint. Now, with a canal cholesteatoma, it doesn't always grow upwards because it's normally formed at the floor of the ear canal or the front or the back part. But it potentially can. So it can go upwards towards the brain, the skull base. It can lead to a brain abscess and meningitis, so infection of the meninges. So it can potentially be life-threatening. It can grow backwards into the mastoid bone, okay, which is the bone behind the ear. And that can lead to mastoiditis and the spreading of infection there. And then you need surgery, a mastoidectomy to remove all the infected bone. It can sometimes grow inwards towards the middle ear. Again, probably unlikely, but it's a possibility, and it can affect the facial nerve. Also, the facial nerve, it does run on the posterior superior part of the ear canal, so it can do damage not only to the facial, because the facial nerve has several branches. It can affect the back part of the ear canal, but the main facial nerve runs through the middle ear near the organ of hearing, actually, near the stapes bone. So it can be very, very dangerous, so it does need to be removed. And what surgeons do, first of all, they may try and treat it with antibiotics and hope that the skin reheals itself, and then natural migration of skin reoccurs. If not, a CT scan is performed to see the extent of this cholesteatoma forming, and they have to surgically remove it. And when they remove it, the key then is to plug in the erosion, because the problem with the erosion of the ear canal, if you've got kind of erosion there, dead skin as it's migrating, it may fall in and then lead to canal cholesteatoma. So they can put some fatty tissue grafts, cartilage grafts even, to plug that pothole basically. So skin as it migrates, it's not going to fall into it. So it's probably not fully revealed itself, and apologies for just coming away from the procedure as well, just to explain what canal cholesteatoma is to you guys. So I'm working on the anterior canal wall, and it's lodged. As I said, it was a really difficult case, but we will get there. Now you can see around the periphery of this hardened wax plug, you've got this kind of almost matrix of white skin. So that's freshly shed skin from the canal wall. And if this was left untreated, these patients can have continuous new layers of dead skin, and it will eventually cause this plug to get bigger and bigger, potentially leading to a keratosis obturans. Have I got time to explain what keratosis obturans is? Yes, I will explain it, because Quite often a keratosis obturans historically has been misdiagnosed for canal cholesteatoma and vice versa. So at the core, a keratosis obturans is a dead skin plug, but it doesn't cause a localized erosion like a canal cholesteatoma. Instead, it causes a global widening of the ear canal. But importantly, a keratosis obturans shouldn't ulcerate the skin. You don't get any proteolytic enzymes. The reason why you get proteolytic enzymes with a canal cholesteatoma is, whereas a keratosis obturans, so let's just go back to the anatomy of the skin. So that epithelial layer of skin, you can actually subdivide that itself. You've got 5 layers. You've got stratum basal layer, which is of the epithelial layer skin, it's the deepest layer. And at the stratum basal layer, that's where new skin cells are formed. And they undergo a process called mitosis. So a canal cholesteatoma, it contains all the layers of the epithelial layer of skin. So you've got the stratum basal, you've got the stratum spinulosum, the stratum granulosum. In the ear, you don't have the stratum lucidum, but other parts of the body you do. And then your most superficial layer of the epidermis skin, which is the stratum corneum. And because the canal cholesteatoma involves a stratum basal, that's why this skin cyst continues to grow and it's metabolically active. And it's in that stratum basal layer as well where it releases these proteolytic enzymes. So that's the key bit there. A keratosis obturans, it's just that stratum corneum layer. It's just the outer, most superficial layer of the epithelial skin. And that layer of skin is completely dead. It doesn't reproduce new skin cells. There's no proteolytic enzymes. So that's a core difference. It's in its almost physiology. So you're beginning to see this is the region here where this patient has a possible canal cholesteatoma. There's a trench, there's an ulceration, there's some keratin there, which I'm going to remove, and you can also see some exposed bone as well. So it may look quite innocuous, and sometimes this is hidden by a thick layer of wet epithelial skin. And it's only until you peel away that skin that this has revealed itself. In fact, I had a patient who attended with her mother earlier this week, and they had previously come here. And it was a time during COVID, so I didn't really recognize her, but she just thanked me because, and I read her notes later and saw the referral, but she also presented with something like this, which I presumed would be a canal cholesteatoma. I referred him to my local colleague who's a NT consultant, and it was confirmed that it was a canal cholesteatoma. Initially, they tried to treat it conservatively, regular cleaning of the ear and also by antibiotics, but eventually they had to operate, and they drilled away all the infected bone so it doesn't spread. And then they filled in that erosion with some fatty tissue grafts, and they were just very grateful. So again, so something like that, you may think, okay, well, it's not weeping, and that's one of the good signs. There's no active discharge here at the moment, so I'm hoping this is caught at very, very early stages. So there's different stages of a canal cholesteatoma. I think a stage 1 is when you get this thick blanket of wet epithelial skin. Stage 2 is when you get an ulceration of the skin. So the skin is definitely ulcerated. Stage 3 is osteonecrosis of the underlying bone and periosteoitis. So that's when the bone starts to decay, which there is some decaying of this bone here. And stage 4 is when it starts to invade adjacent structures and potentially become very, very serious for the patient. So I'm just trying to get in there, trying to get some hard keratin out. I managed to get as much as I could without it being uncomfortable for the patient. And there's some underlying bone that you're seeing there. So I'm just trying to get some keratin off the surface of that. But that yellowy part that you can see, that's actually the patient's temporal bone, the tympanic footplate, I think it is the specific name. Now, we've got this layers of wet epithelial skin, so I want to peel this away just in case there's more than one canal cholesteatoma. Obviously, this is very tricky to do. You need a steady hand, and I would have probably early on in my career when I first started, really struggled kind of peeling away layers of skin like this, but it does come with experience. And of course the endoscope allows you the opportunity to do that because of the view it provides. Fortunately, there's nothing there. There's a bit of dead skin on the front section of the ear canal as well. Now, by the time this patient sees ENT, and I have requested an urgent referral, and even an urgent referral can take a bit of time because of the waiting list. So if this patient is able to, I've advised them to go to see a private colleague who I made reference to earlier. But by the time they see ENT, these erosions are going to be filled with dead skin again. So the ENT will need to kind of peel that away to reveal the underlying potential canal cholesteatoma. That's all the debris that you can see on screen that I removed from this patient's left ear. I really hope you enjoyed this video, guys, and I hope I didn't go too heavy with the explanations, but I know a lot of you do enjoy watching the videos for that reason. Also, I know a few people said the image of the ear is a lot smaller. If you just rotate your the phone horizontal, it will come back the same size as it was previously. Take care, guys, anyway. Speak soon and have a great and blessed weekend. Bye.